Hello.
Yay, you have microphone. We have sound. This is a good thing.
Yay.
I have to mute my phone.
Yes,
We're on an airplane now.
we are. And what is it? You're building the airplane while it's in flight, right?
Yeah, like that.
That's one of the greatest analogies I've ever heard.
That's exactly the analogy. It's like there's that. I leave for Orlando for the Mag Healy launch next week. So you're on your own next week. You can have any guest you want. That would be fun.
I have a list of people that we'll talk about it, about who we can bring on and stuff. Of course, my world is a lot of sports people, but like anything, what the world of FSM has given me is all the other conditions that I never dreamed possible that I would ever treat or ever in my wildest dreams have to even think about.
I had one yesterday that was mind-boggling because the history took an hour and a half. She got COVID in March 2nd of 2020.
So one of the first cases, or I guess, right?
Early cases, and was blown off by Kaiser and then misdiagnosed by Kaiser. And then when COVID hit her lungs, her heart, she had what effectively was a thalamic stroke, then full body pain, then because they didn't know what it was and didn't figure out that COVID affected the blood vessels in the brain and the spinal cord, then she got a psychiatric diagnosis, which meant nobody would see her. So this went on for a year and a half. And I looked at her pain diagram and her heart. She had cardiac stuff. She had tightness in her chest. She had arm pain, hand pain, leg pain, foot pain. And the only exam I did, so she finally found a neurologist that was curious, open-minded, not an idiot. So curious, open-minded, skilled, all that good stuff. So he's been helpful. And then she got mast cell activation syndrome. And I said, well, and 2 months into COVID, she had gastroparesis. And it's like the Vegas. And then a year later, she's got mast cell. And I went, well, duh. And she said, what do you mean, duh? It's like, well, you had gastroparesis. And she said, now she's an OT. She's a medical professional, so she understands language. And I said, well, the vagus nerve is turned off by infection, stress, and trauma, and you had all of the above. And the only physical exam I did on her, because everything about her was so obvious, her pain level was a 7. She had this pain diagram. I said, would you mind if I felt your legs? And she said, no, that's fine. And I went and felt the tone in her quadriceps and her hamstrings, and they were like bricks, and her arm. And she couldn't take a deep breath. And I'm thinking to myself, well, this is easy. And she went on and on. I said, would you mind if I just fixed it? And she said, you what? I said, nothing you have scares me. And if it says, it should be fine. Oh, okay. So in our world, they did have finally imaging that showed that she had some stuff in the hippocampus, which affected her memory, and the thalamus. And it's like, okay, she had a thalamic stroke. That's easy. So that was 40 and 89 neck to feet. But the tone, so quiet down the midbrain, that's what you use for thalamic pain. So that was one machine. Second machine was neck to feet, 81 and 10. I didn't quite understand why COVID would create spinal cord mediated loss of descending inhibition. But I knew how to fix increased tone. That was easy, 81 and 10. So those two started running. And then neck to abdomen, concussion and vagus. She said, oh, that makes me nauseous. And I looked at the custom care and it was just passed 94, 94. And it's like, ooh, ick, here, let me
Yeah.
fix that. So I ran the concussion in Vegas that's minus 94, 94, and that got better. So, and then there's a frequency, the 6 frequencies for the virus that were in the flu respiratory protocol. And I went through the first 2, nothing, and I got to 56, malignant flu. And she fell asleep. And I said, okay, that's the one. So I ran 56 in the midbrain, in the vagus, in the spinal cord, in the immune system. And that just continued on. And then, oh, and the heart, virus in the heart. But there was one machine that ran just on 56 in the capillaries. Just the capillaries. That's where that virus COVID works, is the ACE2 receptor is in the blood vessels that go to everything. That's why the kidneys, the liver, the heart, the lungs, the brain all get, I think, thrashed is the medical term. All get thrashed is because it's the capillaries. So I ran one frequency for the whole hour and a half or 2 hours for just virus in the capillaries. And every time I added a machine, she got sleepier and quieter, and the tone in her legs was like normal. Her body pain went from a 7 to a 0. And her sense of smell came back. All I ran was the capillaries.
Makes
right?
sense.
So
Yeah.
if you look at the ethmoid plate, it's so well vascularized in these little nerve endings. So at the end of an hour and a half, her pain was a 0 to a 1. When I got to when 81 and 10 got to her chest, she could finally take a deep breath. So for reasons I don't understand, when you increase descending inhibition in the spinal cord, it softens from the bottom up in the front, gets to up. She was tight, clear up to her neck and her chin, and then starts up the back. And when it finally got to her hamstrings, then it got to her chest muscles, and we could see her chest relax, I said, try taking a deep breath. Oh, okay. She said, but there's still this pain in between my shoulder blades. Have you ever had an auto accident? Well, yeah, 2 or 3. So I hooked up another machine and just ran inflammation in the disc annulus and told her about Cloward, and the pain in between her shoulder blades went away. So at the end, so it's like you can say to them, honestly, nothing you have scares me. And then you just treat what's in front of you. As Kevin says, do the next thing, right? How do you eat an elephant? 1 bite at a time. Well, you just do the next thing. So as all of this loosened up and all of a sudden she's able to open her jaw, she said, these are sore. And I went, oh yeah, I have a frequency for that. So I programmed a custom care with just 124 and 77, torn and broken, and then connective tissue for the pterygoids. And I put one on each side of her jaw and ran that for 15 minutes. And all of a sudden, oh, that doesn't hurt anymore. So it took from 3 o'clock until 4:30 to just get the history and let her vent. I said, malpractice? It's like, no, can't do that when it's Kaiser. You can't sue them. Okay, fine. So let's just fix it then. Okay. She's just brilliant. So cool. And so I treated her from 4:20 until 3 o'clock, 4:30, 4:40. And by 5:40, her pain was 2 down from a 7, and then treated her until a little bit after 7:15, then had to teach her to walk again. And then her next stop is Dr. Resky because she needs prism glasses, and nobody figured that out before. The she has a vestibular injury secondary to the virus. Not sure why, but it's really clear. I mean, yeah. So that was yesterday.
I'm just kind of sitting here in quiet awe right now for a few reasons. So everybody listening, everybody watching, everybody hopefully knows by now that you and I don't discuss the podcast before the podcast. For the good or for the bad, I sort of like spring stuff on you, topics, themes. But how this podcast started was during COVID. You and I were just doing these weekly Zoom calls, talking about slides, telling stories. And I selflessly decided to share with our conversations, and we started this podcast. So it's really interesting when you start talking about my list, because you essentially covered almost three major topics I want to talk about today. And I was going into today's podcast going, geez, I'm so unorganized, but this has such an organic way of like flowing. One of the big complicated things when I was talking about how I never would imagine myself researching and learning about certain conditions, because when on earth would I ever care about these conditions, is mast cell activation. And in the last year, I am seeing at least a 200% increase in people with mast cell activation, either self-diagnosing themselves or truly getting a diagnosis of it. I'm not sure if it's from the virus or from the, yes, you in the back, your hand up.
Here's the thing. Mast cell activation is not new.
No.
It is the new big scary diagnosis.
Yep.
And what I told this lady, with all due respect, she really does have it, but it's secondary, all due respect to the people that think they can fix it with H2 blockers and antihistamines.
Right.
She does need all those things to keep it under control, but it's not what causes it. It's mast cell activation is the new Candida. Back in 1990 to 2005, everybody that had mast cell activation was diagnosed with Candida. And then I can't remember what was after Candida. But then after that, like in the last 5 years, mast cell activation and what was the cell defense, something or other. And when you look at mast cell activation, they look at it as, because they can describe it as an immunologic cascade, and they can describe it as a cellular thing, they seem to forget that the immune system is regulated by the vagus nerve. So this nice lady, I said, well, hello, once you had gastroparesis, it would be 10 to 18 months before you got mast cell activation. And she went, I beg your pardon? Because she had gastroparesis within 2 or 3 months of the time she got COVID. And it's like, well, of course. She went, what? It's like, once you see the vagus, you can't ever unsee it.
Right.
Vagus nerve controls the digestive system. Her resting heart rate was 85 after COVID.
Right.
Her resting heart rate prior to COVID, because she was a runner and an athlete, was 56.
Right.
After I treated her vagus nerve as concussion in vagus, and then virus in the vagus, and then increased secretions in the vagus, after I did that for an hour and a half, her oxygen saturation was 99% and her resting heart rate was 56.
Wow.
And it's like the vagus nerve controls T cells and macrophages. Mast cells are downstream from T cells and macrophages. And people that they don't think of the vagus because they don't have a way to treat it. They can treat the histamine, yay, because she's on 6 drugs, plus 5 drugs plus quercetin, 3 grams of quercetin a day to control the mast cells. And that's like, why don't you just control the immune system so the mast cells stop being a problem? I said, you stay on all your drugs. We'll get your vagus turned on, see if it stays on, see if your pain level goes away. And then, but mast cell activation syndrome, I never want to get into a intellectual fight with the people like Neil Nathan that, and the other really smart people that are into mast cell activation as a separate cellular phenomenon that's separate from neuroimmune control.
Right.
But that's a fantasy. It's like, hello, they don't think of the vagus because they don't have a way to address it. They have a way to address histamine and mast cells, so they think of that. But they miss the step above it to control the vagus because they don't have a tool for that. You tell somebody to gargle and sing and it never works. Sorry, it's just a hot button for me.
No, and I appreciate it. We all have one. And so I want to take more like the student in the room and the question and answer, because I am treating somebody right now with a history of mast cell, mold, SIBO, Ehlers-Danlos.
Mm-hmm.
And when
You're welcome. I'm sorry.
Yeah, see, this is what I manifest all the time. I'm like, I don't treat, I think I said that the first time I came home from Portland after hanging out with you, I don't treat sick people. So, and like 3 years ago, this person's history would have freaked me out and I would have said, there's no way I can help you. And I just see, okay, she's coming in. This is going to be 2 hours, 5 machines, and I'll take a bite out of each one step at a time. The problem I'm running into with this person is they still have a ton of GI symptoms. Everything else seems to be okay. The person has a custom care. So with somebody with a history like mast cell, mold, Epstein-Barr, Ehlers-Danlos, how long can we effectively think the vagus will stay? Is this person should probably treat herself every night for the vagus? There's no way the vagus, when it's dealing with all those things, is going to stay turned on, right?
No, right. So the vagus, Ehlers-Danlos usually lasts a week. So that's 1 hour sitting in a chair. And actually the first 2 or 3 weeks, it's twice a week, just to make sure.
Yeah.
And then treat the vagus. I treat the vagus and the gut every night. So if she has a converter, that's easier.
Yeah, she does.
So has a converter. When I had, and all of this depends on somebody managing the mold. So you can't kill mold with FSM. You have to have somebody that's doing binders, antifungals, who's testing for mold so you know what critter you're dealing with. The house has to be remediated because the vagus is turned off by Ehlers-Danlos, but also by infection, stress, and trauma. So she has to treat herself every night, but she also has to be getting rid of the mold. And that is, I had one patient, he wants to be able to go back to eating gluten. He wants to be able to go back to staying in a hotel. No, not ever. You have antibodies to mold. I have done. I walk into a hotel, done it in Germany. I did it in Arizona at Neil Nathan's meeting. I did it in, what's that island? Starts with an M. It's south of Spain in the Mediterranean. Anyway, I walk into the room with, the bellman behind me with the cart with the luggage, and I walk in and go, nope, we're not even gonna take the luggage off the cart. Call downstairs, we're changing rooms. Why? Smell the bathroom? No, I do, we're moving. And so when we went to Cleveland, we arrived at 11:30 at night, room on the 12th floor. You just smell mold when you get off the elevator. Got to my room, didn't take the luggage off the cart. Went back downstairs, 12th floor, 14th floor, 17th floor. I ended up on the 18th floor in the 4th room at 3:30 in the morning before I found a room without mold in it.
Wow.
You don't ever to do it. And it's not that the mold in my system is not gone. It's that my immune system can't detoxify mold. It's sensitized and it can't, it's just,
And
Yeah.
when did you find that out about yourself?
Well, first was what I said was I haven't been healthy since 1998. Basically, when I did the remodel in the clinic, I didn't know it was mold, but I knew there was something in the clinic after the remodel that was making me sick. So that got better. Then I got black mold, moved to a mold-free house, but then had a leak in the shower upstairs, and there was black mold in the ceiling downstairs. And so I had 2 mold exposures in the house. And what I knew was I stopped digesting food. And we did pancreatic enzyme testing. I did not make lipase and I did not make amylase. I didn't have pancreatic cancer. So the pancreas just didn't work. So I'm having lunch with Neil Nathan at the symposium in 15 or 17. And I'm taking my enzymes. And he said, "What's up?" And I said, "Oh, my pancreas doesn't make enzymes." He went, "You need to come see me." I said, "Really?" "Yeah, you need to come see me." It's like, okay, fine. So he made me come see him because he knew otherwise I wouldn't do what he said. So I went to Santa Rosa and he says, "So I want you to put your finger down the back of your throat." And I went, "Well, you better move that wastebasket over here because I'm going to, lose lunch." And he said, "Okay." So we moved the wastebasket and I put my finger down the back of my throat. I had absolutely no gag reflex, none, gone. And he put his little flashlight there and he said, "Say ah." Palate didn't raise at all. My vagus nerve was completely gone. My immune system was out of control. I was in primary pancreatic failure because the vagus nerve is why your pancreas makes enzymes. My blood sugar was rising because the vagus nerve is what keeps your liver from making sugar. And my digestion was, I think, sketchy is the word. And then we did urine mold testing. That's where I found out about real-time labs. And there it was. So we spent 6 months and I was getting better. And then I started getting worse again. And he said, "You've got mold in the house." I do not. "Yeah, you do." So that was October. Finally, in January, this is why I know not to argue with Neil Nathan, because it's really hard to win an argument with Neil Nathan. So January comes and George and I went to every water outlet in the house, every place there was water. And in the laundry room, in the hot water inlet, there was one little drop at the top of the inlet. I went, So that was Saturday. Monday, I called the plumber. Tuesday, the plumber came out and he was going to change the valves. And I said, "While you've got the washer pulled out, let's just pull the wainscoting off the wall." So wainscoting is just this wooden thing. Pulled it off, and the drywall and insulation were completely black. The thing had been leaking for probably 1 drop at a time, never any water on the floor, but it went all the way down the drywall, through into the garage, underneath the floor, and down to the joists, into the little half, that's a good face, into the half bath. And yeah, and that's where I found out that when you have mold, especially Stachybotrys, which is the black one, it doesn't make spores. So you could have tested the air and that would have been fine because Stachybotrys doesn't make spores. And I don't do anxiety or depression. I'm pretty, right?
Yeah.
My body was anxious and depressed simultaneously. I was fine.
Right.
But my body was anxious and depressed.
Interesting.
And that was $15,000 out of the savings account, and got that remediated. But there was still something left. So a year and a half later, I'd go on a trip, I'd feel good, I'd come home, and after 3 days, I'd get just tired, just fatigued. That's not right. So then I decided, well, got to be in the kitchen. So we remodeled the kitchen, and when they took the cupboards, when we cleaned out the cupboards, the paralysis that I had on the left side came back that night, and George and Adam had to sort of carry me up the stairs. Then they came and demoed everything, took it down to the studs, and there was a 2x4 at the plate that was gray, and the water had wicked up one 2x4, and there was another 2x4 there, and there had been a leak under the dishwasher. It was black.
Wow.
And the contractor said about the 2x4, oh, that's discolored. And I said, no, that's why we're doing the remodel. So they ripped out every board and replaced it, ripped out mold is a thing, and it doesn't affect everybody the same way. My son and I were sick. George didn't have any trouble with it at all.
Right.
So the Vegas is turned down. Obviously, it doesn't go off, but the Vegas is turned down by infection, stress, and trauma. So while I had the mold infection, my resting heart rate was 87. Now my resting heart rate is 59, 60, where it belongs.
Wow.
The vagus nerve is what keeps your pulse down.
While we're on the Vegas, one of the other questions or comments, I scroll around on the practitioner page for material once in a while, and I went back to yell at the person. I couldn't find the post. Maybe it was taken down, but I want to clarify, nowhere in our educational information do we ever run 40 and 109.
No.
And they were saying it was in one of our courses, and somebody had clarified it wasn't us, it was a different group that talks about it.
And I've never understood the logic behind it.
I was just going to say, could you maybe weigh your 2 cents on why anybody would want to run 40 and 109? 40 is obviously inflammation or decrease activity of, I don't know why you'd want to decrease the activity of the vagus. No educational reason to do that.
I don't get it.
Okay.
And it's like, what scares me is it's part of her standard Vegas protocol on that unit. And it's like, okay, then good luck with that.
I'm not sure if our Facebook group moderator took it down or if they deleted it, because I went to just pose the question, why would you ever want to do that? I don't understand, but yeah. I'm open to that. Yeah. No, that poor little Vegas needs all the support and help it can get. Poor little guy.
Yeah. I mean, I guess if your pulse is 37, you'd want to let down the vagus and jack up the sympathetics.
Right.
But that doesn't happen too often.
Right. I was just about to ask, when would you ever really clinically see that? I don't know.
I've never seen it.
Okay.
That was interesting. Huh.
There's a lot to unpack there. Let's go to a question before I continue. You can read it if you want.
Well, it's like, this is sad.
Okay.
Application of 56 to the capillaries.
Yes.
Detail of how we speak about ACE2 is not a receptor. Well, okay, yes, and regulatory enzyme, well, sort of. Cell surface enzyme protein, which makes that, if it's a protein, it's a receptor. Also sometimes released into the blood, well, because it's in the blood vessels. Reduce angiotensin levels locally to relax the vessel. Yep, allow more flow. The right, the virus enters through the ACE2 receptor, and then, yeah, if it's a protein, it's a receptor. Dad, we'll have that conversation. That's my understanding of it. But it enters the, oh, Kevin found it. It enters the capillaries of the blood supply, and then it replicates inside the blood vessels, and the blood clots happen when it comes boiling out and causes turbulence. So
She's asking about if you're running multiple machines and the second machine is running 40.
oh, okay. If you're running multiple machines, should we pause any other protocol that's running 40 at the same time if the leads are on the same towel? What if the leads are on a different towel? Not to run 40 and 109. 40 and something else isn't mixing with 109 on the towel and messing with. I've never had, that's really a good question, because I ran 40 and 89 and 81 and 109 and 56 and 109, and the Vegas still did its thing.
I don't think that was the one that I saw, but okay.
Okay, got it. Yay, Tom. Okay, cool. So that's where this patient had the thalamic stroke, and the 81 and 10, the spasticity or the increased tone, when you look at that page in Netter, page 65, I think. Anyway, you look at that page in Netter that shows the blood supply to the spinal cord. There are tiny little capillaries all the way down and up the spinal cord. 56, all it takes is a virus hitting one of those little capillaries, come boiling out, and you have a little blood clot, and that creates a long track problem. So she acts ataxic. I mean, she bounces off the walls when she walks, but I think that's vestibular. And the 81 and 10 to reduce the tone, that worked just like it would have if the loss of descending inhibition was caused by a disc. She didn't have disc injuries. It had to be vascular because it came on after COVID. It was really interesting. And not much lung stuff.
Right.
It was all neurological.
That's very interesting.
Oh, and her whole face was tight. So some of the pain and the tone came from 40 and 89, came from the thalamic and hippocampus strokes, TIAs, mini strokes. Interesting.
Very interesting. I want to talk a little bit about that patient's TMJ stuff, because that was a question that we had, but I want to go back to this question because it was actually submitted last week. We ran out of time.
Okay.
It was sent to our FSM Sports Instagram page, and it's a great question. So I'll read it to you here. Hi, I've been looking at the advanced summary sheet and found multiple frequencies for calcium. When viewing the advanced video with Carol, she discussed using all the calcium frequencies in a slide discussing Alzheimer's. I was wondering if you had any more information on what exactly do the calcium frequencies do? I believe 91 and 217 on A have been discussed a lot more, but what about 359 and 606 on channel A? And then there is also 372 on A and 103 on B for calcium in the blood. Where did those frequencies come from? Any contraindications? For example, will there be dire results if we run 359 and 606 on A with 59 and 39 on B? Or will there be a normalization of calcium versus removal? There's a lot.
Yeah, no, there are actually some guidelines about that. So we think of the frequencies as changing cell signaling. It is unreasonable to expect a frequency as low as 606 to change calcium balance in the bone. So dire results, no, but why would you want to do that?
Right.
It's like, why would you do that?
Yeah.
I've done 217 and 91 in the periosteum because you think of inflammation leads to chronic inflammation leads to calcium. Yeah. And it's like getting ground glass in the periosteum. So I've done that before, and that changes pain. The place we don't use calcium, removing calcium, is the heart. So there's the calcium score in the heart, where inflammation leads to chronic inflammation, leads to calcium influx in, and you get a calcium score in the blood vessels in the heart, not in the heart itself, but in the blood vessels in the heart. So making myself my own lab rat, I ran the frequency for removing calcium from the blood vessels and removing calcium from the heart. And in seconds, I didn't feel good, like seriously didn't feel good. So I stopped and thought about it. So calcium channels depend in the heart, especially, make the heart beat. They depend, calcium channels make blood vessels function properly and the heart function properly. So yeah, there actually is a place in the advance where it says, don't run calcium in the heart, and think twice about running it in the blood supply. Because, so this lady she had an 80% blockage of her carotids, and then the next Doppler was a 0 blockage in the carotids, and then she had 80% in one of them again, the right one, and it felt really stiff. So I ran scarring in the vagus, and because it was 6:30, and because she'd had 2 hours of microcurrent, and because the carotid is really close to, so I just left it alone. I said, it feels fibrosed, but let's just see what happens if we treat virus in the artery. So I treated viruses in the capillaries. So we ran 56 in the artery, because the carotid is, a big artery, not a capillary. And it got softer. I said, let's just see what happens, what the artery does on its own if we don't mess with it. Because if the fibrosis is the only thing that's holding the artery wall together, and we take the fibrosis out, that could be like not a good thing. So that's my thought process about it. So you wouldn't remove calcium from, I use it, I haven't ever done it, but I could see using it in dementia patients. So because calcium in Alzheimer's patients, because calcium flowing, there's good studies showing that calcium flows into brain cells and contributes to cell death, apoptosis. So it's inflammation leads to chronic inflammation leads to calcium influx, and that leads to plaque and necrosis and cell death. So that whole first section in the advance that's now 90 slides long, which is why the advance is going to 3 days next year. And we aren't going to have 2 tracks. I promise you will never have to go to 2 separate rooms, because everybody seems to need to know everything.
Yeah, I think gone are the days where there were just physical medicine people and functional medicine or a visceral track. I mean, this is your fault, because we all treat everything now.
I know.
You're welcome, and I'm sorry.
Yeah, you treat what walks in.
Treat what walks in, right?
Yeah, and that was the other thing this patient said, was all the physicians she saw were so compartmentalized that nobody but this one neurologist at OHSU could look at the big picture and how everything was related. Because FSM is a tool that lets us treat, or at least creates the opportunity to approach the whole system more or less at one time.
Right.
Then we have to think upstream and downstream.
Right. And I think a lot of practitioners get overwhelmed because of that. again, it's that, you're welcome and I'm sorry. And I don't think that you have to feel that you're under the gun for that first time you see the patient that has the crazy long list. I love what Kevin just said. You treat what you can when you can, bit by bit, bite by bite. And I think sometimes even you will miss something, right? Either something just you didn't hear it the first time the right way, or people like myself who have been in it a little bit, stuff that we're so used to just letting go, all of a sudden we're like, wait, what did you say? What happened to you? And people think because they're seeing a physical medicine practitioner, they don't need to disclose all the other things in the history. So
sometimes the next layer doesn't show up until the most bothersome thing is gone. So you treat thalamic pain and 81 and 10, get her tone, getting her muscle tone down to normal. Those two things were the first. Getting her vagus nerve to work. It's like having 3 machines to do that that's the beginning. And she's actually not going to get completely better until she sees John Reski. That's just how that's going to go. And I sent her to a GP that's not an idiot, that thinks more comprehensively. Sorry to all the GPs out there that are thoughtful, but so.
When did you start using multiple machines as much as you do?
When I had them.
Right.
25 years ago, I had 1 blue box.
Yeah.
And then I had 2 blue boxes. And then I had 3 blue boxes.
It just seems like we teach and talk about using multiple machines more in the last, I'd say 5-6 years than we did, like 10 years ago. I don't know.
Well, and I keep my programming laptop right outside the treatment room. So twice yesterday, I took the custom care and went and reprogrammed it and brought it back.
Right.
And then took the other custom care and reprogrammed it with something else and brought it back. So I put 5 or 6 things on the clinic units. So I had 2 precision cares. Then I stole 2 more from another room. And then I have 2 custom cares. So I had 6 machines on her. And the other day I actually had 7 machines. I finally matched Ben Catholi. I had 7 machines on 1 patient.
Wow.
But that was unusual. And it's only because even if you just have 2, then you can do 40 and 89 to get rid of the thalamic pain. That's easy, but she wouldn't have been out of pain because part of her pain was the fact that the tone in her muscles was so tight that the muscles hurt from just needing descending inhibition. So loss of spasticity. So just those 2, and then, but nothing's going to get better till her vagus gets treated. So that was 3. And then there was the 4th one, just ran 56 and 109 and 56 in the capillaries. Treated 56, the virus in the capillaries for an hour. And then switched to the vagus, and then switched to the forebrain, then switched to the midbrain and the heart. And so I guess you use them because you have them.
For sure. And it makes treating a patient like that doable in appropriate time frame and not 8 hours, right? When otherwise, how would you ever be able to treat somebody with that type of history so effectively and efficiently?
Yeah. And it's that way I get a lot done. I could have treated her. She was the last patient of the day. So I didn't have anybody after her, and she was so desperate and so brave. I mean, how does somebody not, how, that's the things I can't teach you. How do you respond in the face of the courage not to kill herself? How do I send her home with her pain at a 6? Well, it came down from an 8 to a 6. Yay. No, I just.
Right. I know. And isn't that funny how how some people would celebrate that the pain went down from an 8 to a 6. And then for some patients and some practitioners in certain cases, you're like, no, that's not acceptable. We have to get this down. Let's get to another question before we continue a bit more here.
Paula, hi there.
Where should we start? We'll go to Paula's question first, actually. Do we have anything written up on the mechanism of action of 81 and 10? We talk about it. I've had miraculous results for this with muscle tension and pain with congenital myotonia, and wish to submit an application to our National Disability Insurance Scheme in Australia to fund the purchase of a custom care for a client. This needs evidence.
I talked to Jay Shaw about the model, and the only thing that we could be increasing is GABA. So GABA is the relaxing neurotransmitter. So the mechanism of action is not essential. That's not the first data that you get. Documenting by measuring tone with one of those gadgets. There's some sort of meter that measures muscle tone. It's got a broad, flat, round thing. I can't remember. It's not an algometer because it's not small. It's a broad, flat, and it measures muscle resistance. So the first step, and I haven't taken it, so my bad, but even if I did, I wouldn't have time to write it up. You measure tone, you run 81 and 10, you measure tone in 5 or 6 places, and then do that even on one patient, especially if it's something, whoops, that went away, especially if it's something like congenital myotonia or spastic diplegia and cerebral palsy that's well documented. You measure the tone, you treat it with 81 and 10, you measure the tone, measure range of motion. So in spastic diplegia, they can't straighten their leg because their hamstrings and gastrocs are so tight. And so you measure the range of motion, you measure the tone, you treat them with 81 and 10, you measure that. And then when it wears off, 2 weeks later, they come back in, you do it again, you treat again. That's a single case report. Then you can do a collected case report if you happen to have 2 of such patients. And that is, yeah, so you have photos. What they need are numbers, and because you have to be able to do statistics. So photos are a great anecdote. In order to do statistics, you have to have numbers. So 2 patients, yes. So wait till it wears off, then measure the range of motion. We've got a statistician. I'm happy to pay. We've actually got 2 statisticians. A dynamometer measures muscle strength. Oh, by the way, that was the other wow this week. Patient with a disc bulge in her neck. First treatment, she's right-handed. Her right hand grip strength was 55. Her left hand was 20. Oops, the left hand is the one with the nerve pain. Then at the end of that treatment, the left hand was 30. Then she came back the next week and it was 55 and 40. And at the end of the 3rd treatment, it was 55 and 55.
Wow.
Yeah, so that's pretty cool. But back to Paula. The measuring tone, and I can't remember the gadget. It's not a dynamometer, Denise, but it's something else. And then measuring range of motion with an angle finder, which also has a medical name. And that gives you data that can be compared, and then you can create a statistic out of a number. And that's publishable. And then after that, we need somebody like Terry Phillips to measure GABA and see if 81 and 10 is increasing peripheral GABA, especially in the muscle. I'm not going to biopsy the muscle, but it should be available. It should show up in the peripheral blood supply. So you take a blood spot. I don't know. So the mechanism, 85% of the drugs in the physician's desk reference do not have a known mechanism of action. They do this and that happens. They do this and that happens. We have no idea how or why it happens, but we know it happens. So mechanisms, not so much.
Right.
Great idea.
Do you want to take Nancy's question and then we'll continue on a little bit?
Patient has dystonia, pain in the left side of the face, very tight upper back, mild Ehlers-Danlos, 124 and 77, 40 and 94, 81 and 10, didn't relax anything. Wanted to rule out trigeminal neuralgia, 40 and 396, virus, followed by no change after treatment. Patient reported the next day her face started to twitch. We didn't expect that, totally perplexed. PONS could be messing things up. The other thing that's possible, if you ran 40 and 396, the question is, dystonia is like spasticity in a particular muscle. So that's 81. So you have to increase descending inhibition. So in the past, in a dystonia patient, I've done 81 and 10, 81 in the PONS, 81 and 94. So increase the activity of the part of the brain that creates appropriate tone in that muscle. The other thing that I've run into is if trigeminal neuralgia is just in this top part of the jaw, if it's just in the middle branch of the trigeminal nerve, my next question is, do you have any root canals or deep fillings in this part? So you ran 40 and 396 and virus and 40 in the PONS. Yeah, so 40 in the PONS might have started the trouble. So 81 in the PONS is more likely to correct dystonia. So it comes back to the perverse logic of the nervous system. So loss of function from the PONS causes spasticity. So when the one patient I've seen with a PONS stroke, somebody has a PONS stroke, they become spastic. Somebody has a sensory motor stroke, they're flaccid and then they're spastic. The way to create increasing signaling from the sensory motor stroke, or in the one case, the patient that had a PONS stroke, we increase secretions in the PONS and that relaxed the spasticity. So quieting the PONS further. So if the PONS is dysfunctional for whatever reason, and you quiet the PONS, it's a possibility that you made it worse, which would have gone from just increased tone, which is dystonia, to twitching. And the thing is that I can understand you being totally perplexed, because there are places where it doesn't make any sense until you can get your head around the concept of quieting the activity of the cord versus increasing descending inhibition in the cord. And you don't learn that until you make a mistake. So now you're aware. So I made a guy in a coma cry by running increased secretions in the midbrain. So I don't do that anymore. I've gotten rid of phantom limb pain is like easy. And thalamic pain from a stroke is easy, not permanent, but easy. It's just 40 and 89. Tell the midbrain and the thalamus to just chill out, right? So the other thing you can tell the patient is it's not going to be permanent. Can't be. All we're doing is changing signaling. You can quiet the activity of the PONS. It shouldn't last for any more than 24 to 48 hours, because all we're doing is changing signaling. Right. So it'll be fine.
The next question kind of segues from Anonymous. Can you explain your comment that treating nerve pain is easy? Yes, I know. What exactly is done to make it easy? Thinking post-surgical nerve pain. That's probably it's probably the easiest one, but
It sounds weird.
I know, right? Like when you, because it is the hardest thing that you could probably treat before this,
I
right?
know.
Very frustrating to treat nerve pain.
Every from the first time that I ever treated nerve pain, it just made a certain amount of sense that nerve pain was caused by inflammation on the nerve.
Correct.
So we have a frequency for inflammation, we have a frequency for the nerve. And as long as the nerve has not been cut, then it's how do you get rid of nerve pain?
Right.
You reduce inflammation in the tissue that is the nerve. So it's 40 and 396. If the nerve is cut, you have phantom limb pain. So when the brain has lost input from a nerve, so they do an amputation, they cut the nerve, or in one patient's case, they cut a cutaneous, it was the one that had this deep pain inside after a lumpectomy and radiation. And they took out 14 nodes, 12 of which were positive. And it's this deep pain. And I'm looking at it, and I did 40 and 396 and it didn't change. Then I treated scarring in the nerve, and that changed a little. And then I looked at it and went, what if they cut the nerve? What if she basically has phantom limb pain in her armpit? Phantom limb pain in the cutaneous branch of the brachial, whatever nerve that was. So I ran 40 and 89. It's phantom limb pain. And this deep pain went away and stayed away. I didn't expect it to last, but it did. So treating nerve pain is easy only because it never doesn't work.
Right.
As long as the nerve has not been cut, you run, and the other piece of treating nerve pain is the contacts have to go from where the nerve starts to where the nerve ends. I had one associate one time training in my office, and I can't ascribe why she did this, but in spite of being told you have to go from where the nerve starts to where the nerve ends, she put the patient in a rocking chair, run it neck to feet, and run 40 and 396 when the problem is in the arm. And that's a good face. So it's, if you have to go, the contacts have to go from where the nerve starts to where the nerve ends. So it goes, if it's a thoracic nerve root, go from the spine to the front.
Right.
If it's L5 and you put the contact at the low back and it stops at the knee, doesn't work. If it's L5 and you put the contact at the low back and it stops at the ankle, the toes still hurt. Mm-hmm. You have to put the contact at the low back and wrap it around the toes at the end of the nerve root.
Right.
And it's a combination of the current. I swear, this is why once I retire from the clinic, I am going to be the oldest PhD student in neuroscience at the University of Washington, because I want a squid axon. I want to look at voltage gated ion channels in a squid axon and find out what we're doing. How are we doing this? The current has to be polarized. Yeah. Alternating will work, but it's slower.
Yeah.
There's only two frequencies that work, 40 on channel A and 396 on channel B.
Yeah. Unless
it's cut. And then it's 40 and 89, but you can't find that in a squid axon. You just have to use the nerve. And it's easy because it's never been hard.
Well, and I think, when we're starting off in our FSM journey, when we're these little fledglings in the nest and we're just trying to make little dents in cases, 40 and 396, I think universally has been the frequency that most of the newbies were like, oh, well, the pain, we tell people run that right away because it drops the pain down. In the sports course, where do I start? Get them out of pain first. 4396. And you talked a little bit about 13 and 396. I find that they kind of work hand in hand. I always start with 40 and 396. And if it's not blowing my hair back, maybe that nerve is scarred, try 13. Or sometimes I think that it's scarred. So I'll start with 13. And you just said it, it'll take the pain down a little, but not enough. And I think that is, we talked, I think it was podcast number 1, like if you could pick 5 frequencies, what would they be? I think that's universal. 4396 has to be on your top 5.
And the other thing that I did with this Vegas lady yesterday, well, this COVID virus lady, she got all out of pain. She said, except right here. And she pointed right behind her ear.
Oh.
And I went,
scarring in the Vegas? Yeah.
Oh, you get chocolate right there. I said, that's the jugular foramen. Yeah. And I ran scarring in the vagus, and that pain went away, but then it went down to here, and the vagus follows the carotids into the vocal cords. So I treated scarring in the vagus all the way down here. There you go.
That is, I've had 2 patients now that have come to see me from different parts of California who were treated by FSM practitioners for migraines and headaches. And they both pointed to pain right through here. And that's scarring in the vagus. And after the first lady left, she's like, I just pulled over to let you know that changed my life. I'm like, well, just wait.
What created the scarring in the vagus?
What's that?
What created the scarring in the vagus?
It was a car accident.
Yeah.
And then she got an infection in the hospital after the car accident.
Oh, ow.
Infection, stress, and trauma, all in one bundle.
Multitasking.
But I had treated the vagus, but it was scarring in the vagus that created the most change.
Yeah. No, that makes perfect sense.
And then the SCM and the scalings just turned to snot.
Yes, exactly. Smush.
Yeah. Smush is snot. Somebody had written, I love how Kim is ending with certain quotes. So I'm going to stay on this one. I found it's so funny how it all overlaps and it all works out. And you've probably heard this 1,000 times, but it really ties in for today. Be proud of your scars. The scar is a reminder that you were stronger than whatever tried to hurt you.
Amen.
Until we dissolve them. But
you get to keep the strength.
Exactly.
That's every injury, every recovery carries with it a gift.
Totally.
Then when you learn the lesson, you get to get rid of the condition, if you're lucky, but you get to keep the wisdom. You end up with more compassion for yourself. And the lady I treated that had the disc and the increase in grip strength, and I said, there's a word you can, now she is used to lifting cords of wood, and she was in Alaska and she was doing all this physical stuff, and that's how she re-injured herself. I said, there is a phrase you get to use. Are you ready? Yep. It's not that I can't do it. It is, I'm not allowed. I'm not allowed. For 3 months, I'm not allowed. 10 pounds, elbows at your side, I'm not allowed. Then after that, you can do whatever you want.
Very good.
Have time to heal and keep the wisdom.
Right?
Yeah.
Oh, I love this. This was like, I took like a selfish one today. I learned so much. Thank you. I love our Wednesdays.
I love
I'm going to miss you next week.
I am. I'm going to be in Florida.
You're going to have so much fun.
You're going to have somebody fun on?
I'm going to have somebody fun on, and I'm going to talk about some fun stuff. It'll be a surprise. You'll be proud.
I'll listen. It'll be fun.
All right.
Hey.
Have a great rest of your week.
I will. You too.
And we won't see you next Wednesday, but we'll see you the Wednesday after that.
I'll see you after that.
All right.
Bye.
Please leave an honest review wherever you subscribe to this podcast. The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and and, unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.